Good morning.
Good morning.
How are you?
All right, and yourself?
I'm well. I am well. Down here burning up in the south. Like, woo, it's hot. When you get into that sunshine and it's a whole different conversation. We like, we can't talk long. We gotta either find a tree with some shade or we need to talk on the phone or something. I don't know. Doing the most. How are you? How was your week?
It was pretty good. How
Okay.
about yours?
It was okay. It was good. I was productive, believe it or not, more productive than I usually am. So I was excited. I get to tick some things off. Like, woo, yeah. Got
How
a
was the drive?
drive is fine. I never have a problem with the drive. I left. Um, well, I got here in the nighttime. That's different. I normally try to. I like to travel during the day. So once upon a time, I don't know if I told you the story. I was coming home from my husband and I. We were coming home from Indianapolis. We went to go. Where did we go? We went to a concert. We went to see Raheem Devon. I love him. But anyway, so went to go see the concert, and a deer, two deer actually. So I drive in the fast lane. So I'm driving in the fast lane, and then there's a semi truck next to me, and right in the middle of nowhere, as we're approaching, there are two deer that are just standing there looking at us like, hello. I'm like, oh my God. So I'm trying to veer. And Ricky's like, girl, don't you see this truck right here? You trying to kill me? And he was like, you're going to have to hit it. And I said, no. He was like, you're going to have to hit it. And sure enough, as soon as we got close to it, one of them darted. The other one jumped and I hit the bottom of his hind legs. And so I think I had post traumatic stress disorder behind that for a long time. I wouldn't drive at night. Um, I still get funny about driving on the highway at night, but yeah. So when I left home, I was like, "Oh my God, it's gonna be nighttime." I said, "But I'll be close, so I'll be good," which I was close enough. I was like
Good.
30 minutes away, so it wasn't too bad. I was like, "Oh my God." So yeah, now in the morning dark, I'm cool with that because I know light is coming. But nighttime dark, I'll be like, "Oh my God." And that was when I used to drive. I used to be like, "Okay, driving through the middle of the night. Let's go." I can't do that anymore. So yeah. Mom ain't got it in her like that no more. So I don't do it. But other than that, it was fine. It was fine. I go home tomorrow. So I'll be pulling out early in the morning and get home tomorrow afternoonish to prepare for the
Okay.
week. Like start the show all over again, right?
Can you believe it's August?
No. No. This year is flying with all of the crazy twists and turns that are happening. This year is flying. I don't know if that's a good thing or a bad thing, but this year is flying.
It
Isn't
is.
it amazing? All right. So, uh, full disclosure, I'm not at my regular place and I don't even have my regular computer. I have my regular work computer, but not my regular production computer. So I'm all over the place. So please bear with us. Thank you. All right. So, what if the agency that pays every single one of your claims just stood up in the Federal Register and called the code set you deal with a monopoly? Welcome to our Saturday morning tea, where we brew up the hottest topics in healthcare. Every week, we're covering HIM news, education, the traveling and hitting of a deer, and this hot southern heat, certification tips, entrepreneurship, and revenue cycle at large. And if you're new here, go ahead and hit that thumbs up or like button right now. It really helps us out. I'm Clarice Warner, the Girl with the Pearls, founder and senior education director of the Professional Reimbursement Network, LLC, aka PRN. And we are a healthcare compliance consultancy located in Cincinnati, Ohio, specializing in revenue cycle, regulatory compliance, and education. Now, have you ever wondered what it actually takes to become a certified marketable medical coder? Not just certified. but marketable and even employable. Have you ever wondered? Well, before I introduce my co host, let me share with you free information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Hey. If you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. All right. Here we go. All right. Joining me today is my partner in success, my co host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good
I'm getting
morning,
there.
everybody.
Okay.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I left the bedside to transition into risk adjustment in 2014. During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going for you?
It's coming along.
It's coming along.
Yeah.
Okay. All right, there we go. All right. I told you. I'm using somebody else's dual screen. So it's like, uh-oh, here we go. All right, now get back to where I need to go. There we go. All right. So if you got comments or questions as we go, drop them in the chat. And if it's a question, start it with a Q so we don't miss it while we're talking. We want to make sure that we answer all the questions that we see. All right. So whether you're brand new here or you're a replay watcher joining us later, today we are asking, is the CPT coding system, as we've all known it for almost 60 years, actually a government protected monopoly? And what happens to your job if CMS decides the answer is yes? But first, before we get into it, a couple of housekeeping items. Our PRN Hot Tea Sippers and PRN Elite Patreon tiers both have new resources dropping tied to this episode. You have the quick reference materials for our Hot Tea Sippers and a deeper executive briefing for our elite members. So if you're interested in being part of our Patreon, feel free to check out the description in this video. Also, we have the QR code posted there, so you can also check that out. And as always, thank you to everyone who's already part of the Patreon family. You keep this tea brewing. But let's now get into our church announcements, shall we? Yes, we can. Can we kick it? Yes, we can. Okay, there we go. I don't have a fan. I forgot to bring the fan.
Don't worry.
You holding it up for us all. I just thought about it like, you see me look over to the side. Like, this is not even my house. This is not even my setup. Oh. Hey. All right. So, speaking of codes changing the data, the Centers for Disease, or the CDC, the Center for Disease and something, I'm missing the whole thing it stands for.
The CDC, Centers for Disease and Control.
It's control. I thought it was, but it didn't sound right to me. Published a brand new morbidity and mortality weekly report. It's the MMWR. And they published this on August 6th that every coder needs to see or know about. I was unfamiliar and I said, well, wait a minute, what do we have here? Because there was some information. So in this particular issue, when a specific ICD-10 CM code for cannabis hyperemesis syndrome, that's a whole thing, R11.16 took effect on October 1st, 2025, emergency department visit rates for that condition more than tripled overnight, from 3.35 per 10,000 visits in September of 2025 to 11.26 per 10,000 in October. 8 months later, the new code has surveillance data running 3.7 times higher than the pre-code average. The increase showed up most among patients aged 15 to 24 and 25 to 34, and among Hispanic, Black, white, and multiple other race patients. Across the whole post-code period, the highest rates by far were among the 15 to 24-year-olds at nearly 39 visits per 10,000, followed by Black patients at 17.6 per 10,000, and females at 12.65 per 10,000. The CDC's own read is that this jump almost certainly reflects better clinical recognition and coding, not necessarily a sudden spike in cases. So if you've ever needed a real-world example of how the codes we assign shape the data everyone downstream relies on, this is actually it. Mr. Jesse, do you have any church announcements?
Actually, I have I wanted to talk about that actual code because I think it was it last year or earlier this year? I had a case like that.
Really?
As soon as you said the name, I was like, that sounds familiar.
Yeah.
And it was a young person, so
Yeah.
it fits. Yeah.
And I think the article also spoke to, so like they said, they're not necessarily stating that there's a spike in cases, but they did reference how there are a lot of states where cannabis use, and specifically things with THC in it, are legal, but federally it's not legal. And I think that's the crazy work right there. Because you may be in a state or a city that is where it's legal, but maybe you walking on a sidewalk on federal property. What happens then? So there's a lot of nuances for those who partake, but just be mindful and be careful. And then I think this particular diagnosis occurs with consistent, constant use. So there are some side effects. Yeah, I know a lot of folks like to be like, oh, but it's of the nature and of the earth and all of the things, but there are some side effects. And not only with the, I think, smoking of it, but even the ingesting with, some of the edible products and that kind of stuff. So be mindful, stay informed.
Tanika just said, I've been seeing it often, and I think that's Colorado. Well,
Okay,
Colorado, first of all, I
think
think, weren't they the first people to have dispensaries?
I believe they were. I think they were
So,
one of the first.
I can imagine. It's probably off the chain there.
It wasn't. They're not the mile high for nothing.
I'm telling you, you can't find a candy bar nowhere near around them people.
It ain't safe. It ain't safe.
No.
It ain't safe. Oh my goodness. All right. Okay. Well, let me get all of this down and all. Oh, banners. Okay. Now I can focus. Stay to the comments. Oh, she's laughing. All right, so let the tea spilling begin. Again, good morning, and welcome back to the Saturday morning tea where we serve up the real talk our profession needs. I'm Clarice Warner alongside Mr. Jesse, the coding nurse. We meet every Saturday morning right here to keep you informed, educated, and ready for whatever this industry throws at us next. To everyone who's been here since week one, thank you for coming back. We love it. Get your cup and come on in the room. I do have a cup. I don't have my regular cup, but I do got my tea. Yay. All right. So let's talk about what CMS actually did. Okay, tea sippers, let's set the scene. On July 16, 2026, the Centers for Medicare and Medicaid Services, or CMS, published the calendar year 2027 physician fee schedule proposed rule in the Federal Register. We talked about this last week. Now, buried in there, because there's a lot of stuff in there. And like last week, I picked out those things that jumped out at me. I guess I didn't go deep enough because this would have been something I would have talked about. But buried in there was Section 8H, which starts on page 43951 and goes through 43953 if you're interested in reading the information for yourselves, is a request for information or an RFI. Now, I mentioned last week that there were a lot of RFIs in this particular proposal. This one is about Current Procedural Terminology Coding System, aka CPT. The code sets every one of us uses every single day. Now, an RFI isn't a proposed change. CMS isn't saying we're replacing CPT on January 1st. No, nothing like that. What they're doing,
Unfortunately.
stop. What they're doing is asking the public, asking us a set of pointed questions about whether the way CPT has worked for the last 6 decades still makes sense. And some of the language they use to frame those questions, it doesn't hold back. So CMS spent real space in this rule walking through the history, and the history matters because it sets up the whole argument. So CPT was introduced by the American Medical Association, our friends over there at the AMA, back in 1966, originally to standardize how procedures got documented in the medical record and to help communicate accurate information for insurance claims. In 1977, the AMA established CPT-4, which was the 4th edition, which gave us the 5th-digit numeric structure we still use today. Then, in 1983, the Health Care Financing Administration, remember them, HCFA, which later became CMS, required the use of the Healthcare Common Procedure Coding System, or HCPCS, for physician services. And here's the key detail. CPT essentially became and has functioned as HCPCS Level 1 ever since. After the Health Insurance Portability and Accountability Act of 1996, or HIPAA, passed, the Department of Health and Human Services, or HHS, interpreted the law as requiring HCPCS and CPT-4 to be used in combination as the national coding standard for physician services. But, and CMS is very explicit about this in the rule, that's HHS's regulatory interpretation. It is not something written into the HIPAA statute itself. The law never actually specifies the balance between the two systems or names CPT by name at all. So here's where it gets more interesting. New CPT codes come from the CPT editorial panel, established after that original 1966 publication. Once a new code is defined, it gets a payment value from the AMA's Relative Value Scale Update Committee, or the RUC, which was established in 1992 after CMS moved to the resource-based Relative Value Scale for paying physicians. CMS points out in its own words that there's a long-standing concern about the federal government relying on a private organization with, quote, an obvious conflict of interest, end quote, in providing information on the time and resource requirements to conduct physician services when that same information influences their own payment. And this isn't a new complaint. CMS cites nearly 20 years of criticism from MedPAC, which is the Medicare Payment Advisory Commission, saying CMS has, quote, over relied on specialty societies with a financial stake in the process, end quote. There's also a 2025 report from the National Academies of Sciences, Engineering, and Medicine recommending alternatives to the RUC for valuing primary care. As CMS goes a step further, tying this to the Make America Healthy Again priority, suggesting that historic reliance on the CPT and RUC process may have contributed to a, quote, sick care, end quote, system, one with limited emphasis on prevention and lifestyle change, because the coding system rewards procedures more than it rewards keeping people well in the first place. Mr. Jeffrey, what you want to
Well,
give me?
you know, I have never liked CPT,
We know.
but I think that this is the government's attempt, and it's going to be interesting to see because these doctors are going to fight it tooth and nail, and Dr. Oz is going to have every country club membership revoked that he ever belonged to. But I think that this is the government's approach because honestly, the way CPT is set up now, you can't bundle it. You can't put it into clear buckets like you can with risk adjustment, like you can with DRGs, and like you can in home care with, I think it's called PDGM. They're all moving to that whole risk adjustment payment bucket type model. And with CPT currently, you can't do that. And I think that's what that's been their goal for years. That's what they did most recently in healthcare. Home care. They've redone home care like the past couple of years, and it's nothing like it used to be because it used to only be fee for service too. But and I think that's where they want to actually take outpatient, and I will love it. Plus, there's way more money overpaid by the government in outpatient services than any other part of healthcare.
Well, because it shifted, healthcare shifted from an inpatient model, focusing, when you got sick, even when maternity care, when you came to deliver your baby, they were like, okay, thank you, here's your baby, bye. They were pushing the folks out quicker and quicker. So even back then, I think was the start of some of that they had to rein back in because they didn't think that all the way through. Like there are tests, there are things that you have to monitor for. There are all kinds of things that you need to do within them couple of days that baby was born. So sending nurses to people's houses and all of that foolishness. So they reined that back in, but there is still the shift where we are only treating or taking care of the sickest acute patients in the hospital setting. Everything else you can follow up, monitor, do all of the things on an outpatient basis. And so that shift has been coming and moving for years. All right, so let's break down exactly what CMS is asking, because these are the 5 questions that matter if you want to submit a comment. Now, I know some of the comments that I saw, especially on LinkedIn, was about which system they liked versus they didn't like. And I don't know if that's an appropriate way to dissuade one way or the other. Just because you like something doesn't necessarily mean it's the best system or not. But they were just coming full for, oh, I like this. Oh, I like that. And I was like, but okay, but give some more, give more. Well, CMS was real clear. They have these 5 questions that they want you to consider when commenting. So question 1, what evidence exists of harm from the AMA's monopoly over CPT-4 licensing. They're asking about innovation behind inhibited and about acquisition or I'm sorry, innovation being inhibited and about acquisition or maintenance costs tied to CPT licensure. That one piqued me right off the top because I remember somebody got in trouble. I want to say it was an educator that wasn't necessarily tied to an educational organization was doing something with CPT, and they were like trying to come after this person because they didn't quote unquote have the license to use CPT in their educational courses or whatever. Something happened. And I know it's also a big deal with people publishing. If you're publishing type coding manuals and that type of thing, using CPT without licensing has always been a big deal. And do you know how much it costs for that?
I have no idea.
Sir. Y'all talk about AAPC and their licensing stuff and AHIMA and their licensing stuff when you're on education. And on top of that, the thousands of dollars that you need to have annually for CPT licensing. Bananas. But anyway, so that has been a real thing. Even though, let me just say, recently, because I did it last year, there's some kind of committee, some kind of something that affords you the opportunity to get a license if you're doing innovative work. If you're doing something, you have to show that you're doing some type of innovative work or something related to CPT. And so they grant you, I think it's a year's license for that. And then they have these meetings, you come together. We talked about, the things that people did. A lot of it was, around education. Some of it was, putting together kind of, that's why you don't see a lot of things app type of situations, because you got to have the CPT license and all of the things. And I think that right there is where the quote unquote monopoly comes into play. Because, even with the manuals, you can only get your manual from the AMA. Whereas, with the ICD-10 CMs and even PCSs, you have options.
Yeah.
There are no options with CPT. You either go into the AMA or not. So that was question number one. Mr. Justice,
But
you have anything to add on that? Go ahead.
So for number one, I think the first thing when you read the question, the first thing that came to mind is overpayment. It's hard to regulate, which is why they're having this discussion anyway.
True. Question number two: is there evidence that CPT-4 code generation actually follows a real process of identifying medical necessity? And what could other systems or populations or other countries teach CMS here?
That's interesting because internationally, there's only two code sets, a disease and a procedure, regardless of where you are. But here, the procedure depends on where you are, if it's inpatient or outpatient. And they don't have that internationally. There's just one standard procedure. And I'm sure there are differences, for an inpatient procedure. I'm sure that that's built in some kind of way, because I just read enough to know that they have a diagnosis code set and a procedure code set. That's it.
Okay. Interesting. Question 3. If CMS revisited the HIPAA era coding standard, what alternatives to CPT-4 exist? Would CMS need to establish an entirely new legal standard, or could they simply allow private competition to supplement the existing CPT-4 system?
Now, What I think the AMA is going to fight purely because of the money, because right now that they own everything.
Can you imagine
And
the hit?
yes, it's going to be a whole lot of mistresses that are going to be door dashing.
Oh my God. Be like, I ain't got nothing extra for you, sweetie.
Hey,
Go
that's
on
all
out
I
there and
got.
get your
That's
toys.
right.
Oh my God. Oh my goodness. Mm-mm-mm. That'd be interesting too. But
No, you
so
see
my
the
question is, why
downstream
now?
effects.
They've had this, they've known about this lack of competition in this particular area. Um, she's saying Amazon Flex. I cannot.
Yes.
Wait a minute, let me just put these on here so they show. Okay. Yes. Okay. Oh my goodness. Um so I'm thinking, like, I know there's new administration and all of that, and maybe that's the reason why, but like, why now? Why? Because they was
I'm
that y'all, them your people, y'all Ace Boom, the AMA and the folks. What is it? What's the twist? Is it Oz is the twist? I don't know, but why now?
what in my humble honest opinion, I think that it all ties in. Everything comes back to bite you when you don't think so, because this to me is a fallout from Doge. Because if you want to talk about government efficiency, there is nothing efficient about CPT and all this overpayment. And the thing is, the reason why there's so much overpayment is because there's not enough auditors. It's too many providers. I mean, it's a gazillion outpatient providers, and only a small percentage of those records get audited. So, and from the records that they do audit, they see that, hey, we're spending a lot of money. So, in an effort to save money, this is a cost saving measure.
Hmm.
And from that standpoint, I can see it.
Hmm. But they audit hospital records as well. They're
Right.
not
But
immune.
no, but the thing is, here's the thing, because I was trying to find out while you were talking, the recovery rate for inpatient is way lower than for outpatient, because of all the checks and balances. Like you have DRG, you have all these companies that audit, these records. You have people in house for these facilities that do a check, but they have DRG validators inpatient and on the payer side. So there's a lot of checks and balances to make sure that it's right.
And there are organizations that have that on the
Oh,
provider side, especially
oh,
the
oh,
ones that employ physicians or providers.
I'm not disputing that, but I'm just saying, but the money that CMS has identified that they in overpayments is way larger on the outpatient than on the inpatient side.
Hmm. Interesting. Interesting. All right. Question 4. What are the benefits and the drawbacks of paying for physician procedures based on the International Classification of Diseases 10th Revision Procedure Coding System, or ICD-10 PCS, instead of CPT? And could those procedures be grouped into broader payment categories, the way Medicare already groups inpatient stays into MSDRGs or outpatient services into APCs, instead of pricing every single CPT code one at a time? I think that's the clear, maybe possible introduction into where this is going.
Mm-hmm.
And wanting to get, I can't wait to see these comments.
Yeah.
I can't wait to see what when the final rule comes out and the comments are released, because if you comment, they usually publish your comments, so you get to see the comments. Sometimes if they're all the same, they will kind of lump them together, but I think there is some record somewhere that lists all the people or all the folks that may have commented. And I think this would be a great one for people to comment. I'm actually thinking about submitting a comment for this just to see how. Okay, the grandbaby is having a fit because she can't come in, but to see how this may to see how this works. All right. Question 5. What objective alternatives exist or could be developed to the current AMA, CPT, and RUC committee process? And would those alternatives support or actually inhibit innovation? I mean, I feel like they going after all of the things, dismantling their whole process one by one. So not only this, but also that. So it's gonna be interesting. I think it's gonna be real interesting.
I mean, and honestly, I think that I applaud them for even having the initiative, but this would take years to fully implement.
Oh, absolutely. This is not going to happen. Like I said, this is not going to go away next year, even if they decide one thing or the, but first they have to decide which way they want to go. And then from there, you're going to have to build all of that out. It's going to be a lot. Well, public comments on all of this, along with the rest of the calendar year 2027 physician fee schedule proposed rule, under file code CMS 1848P are due September 14th. So you got a little time to think about it and put your comment in there. This is this could be a test run. And really they would truly be interested in those of you who are actually using these systems to weigh in. I mean, some folks from the outside looking in have some thoughts or whatever, but we're the people that are actually using this every day. They want to hear from us. Well, let's talk about what the industry is already saying. So now this RFI has not stayed quiet at all. The word doing the heavy lifting in almost every headline is monopoly, because CMS used that word itself directly in a federal regulatory document. Now, health policy and legal outlets have called this the most notable RFI in the entire proposed rule, touching medical necessity, licensing barriers, alternatives to CPT and the RUC, ICD-10 PCS as a payment basis, and alternative governance structures altogether. On the digital health side, commentary has focused on CMS asking what patient care improvements have been, quote, diverted or delayed by the AMA's CPT-4 monopoly, including inhibited innovation and the cost of licensure itself, end quote. And this has gone political. Republican Representative Diana Harshbarger of Tennessee, who is a pharmacist by background, put out a statement saying that CPT has, quote, become essential healthcare infrastructure, yet it remains controlled by a single private organization that faces no meaningful competition, end quote. This also follows a 2025 letter from Senator Bill Cassidy to the AMA expressing frustration over its licensing practices. Specialty societies are watching closely too, and there's a real tension here worth naming. Some of the same organizations flagging the conflict of interest language are organizations whose members actively participate in the RUC process to advocate for their own specialties' relative value units. That's not a criticism. It's just the reality of how the current system works. And it's exactly the kind of dynamic CMS is asking all of us to weigh in on. And as, go ahead, you had to say something.
No, finish.
Oh, and as of this recording, we haven't seen a public response from AMA leadership, AAPC, or AHIMA directly addressing this RFI, which tells us the trade, press, and legal commentary are ahead of individual practitioner conversations right now. And that's exactly why we're bringing it to you so you can hear all the deets. Yes, sir.
I found the information I was trying to talk about. So it has claim type, improper payment rate, and improper payment amount. This is for fiscal year 2025. So for hospitals, in the inpatient prospective payment system, the improper payment rate was 3.5%, and the amount is 4.61 billion. For Part B, the improper payment rate is 8.44%. That's more than double. And the improper payment amount is 9.62 billion. So that's like twice as much.
Right,
So,
because again, things have shifted to the outpatient, so they get way, way, way more claims out.
But this was saying that that the inpatient has, I mean, because they're just the volume of claims period in this country is just amazing. But it was saying that inpatient has, of course, a higher dollar amount, but they have the lowest recovery because of all of the whole audit back end and all that. I mean, that's what I've been doing for the past 3 years, back and forth, this side, that side, fighting over, money. And it's not, I mean, I just did was it last week or was it early this week? I did an appeal. The amount, actually, it wasn't valid. They lost $100,000 on that claim.
So coming back to one of the questions, it just hit me. So why would CPT be involved in deciding or determining medical necessity? ICD-10 PCS is not necessarily involved in I thought that's what the diagnosis was for. So why would the procedure be? I don't know why. I don't understand that part of the conversation.
You know what? I kind of think this is just I can kind of see it because PCS is cut and dry. Like if somebody has osteoarthritis of the right knee and they have a right knee replacement, like the code is the procedure code is very clear. This is what it is. But when you have, E&M codes, when you have add-on codes, of course it can be done because they've been doing it. But I think it becomes like, I mean, then when you get into like, what if somebody has a separate procedure during a global period? I mean, logically, we know that there are CPT codes that would explain it. But I think that it gets harder to track and figure out because you would have to really, really audit the record. You can't look at a claim and say, oh, well, it's that. You could eventually get to it in outpatient, but with all the modifiers and then the multiple codes for that one procedure, which far outweighs just one diagnosis code, one CM code. You could have two, or for a procedure, you could possibly have 4 or 5 CPT codes along with modifiers and all that to kind of like muddle through to figure out what exactly was going on.
But again, how does that? I mean, I'm still lost in the sauce on. But how is that part of the medical necessity conversation? Because again, your diagnosis indicates whether or not a particular procedure is necessary. So the procedure itself, or codes for the procedure itself, doesn't. That part. Maybe I need to do a little more digging. That part I don't understand why that's part of the conversation.
Oh, I definitely understand what you're saying, but I've always thought that outpatient coding was convoluted. I always thought that, and especially and now even before I got into PCS, I thought it was. But once I got into PCS, it's just so much more streamlined. Not that it's easier because it's still a different.
It's different. I don't think it's necessarily easier.
Right. But it's
because you hear the people who don't like PCS either because of what you were taught, what you learned, even in from the basics of medical terminology don't necessarily jive with the way those
it's
things
not a
are listed.
one-to-one.
It's
No,
not
right.
one-to-one. And so that piece, now I love the structure of PCS because it
Right.
is like putting the pieces together or pieces of a puzzle together. You got this, make sure you had this, you got that. So I get that part. And CPT doesn't have that. And to your point, the way that they make up for that if they need to is with the modifiers and adding additional codes if needed or necessary. So I get that part. It's just that just hit me like, well, what is the medical necessity? Why is that part of the conversation? I'm curious. Maybe I'll do a little more digging to find out.
Because if you think about improper payments are always about medical necessity.
Absolutely. But the reason why they had to have the service was because of XYZ diagnosis. And
Allegedly.
if that diagnosis isn't part of the medically necessary reason that service would have, that's your key, not the procedure, I would think. But I don't know. Maybe I'm missing something. Maybe there's something that just is blatant and obvious that I'm not seeing. I'm like, well, why would you tie that into those questions?
Because I just find like I just find that it's, I don't know. Overall, I just think it's easier to audit inpatient than it is outpatient. I've always just thought that, because not that these cases aren't complex, but it's easier to just muddle through, like to get through it. Like
I think it's easier because you have more information. Within an inpatient stay, you got the whole story from what happened when they hit the door to when they walk out the door. With professional services, you don't necessarily have that. I mean, it's each encounter, and the way these electronic medical records are set up now, where everybody copy, cut, and pasting.
Right, but each encounter is supposed to stand alone, so you're supposed to have all the information.
Supposed to, but if it's copied from the one before, is it really truly standing alone?
And this is how this is why and how we're here today with them trying to get rid of it, because they don't.
So again, as we always talked about, it comes back to the documentation. I don't know why is that not part of the conversation? I think that's probably more of the conversation versus the medical necessity piece to me, because again, I'm not understanding that part. But yeah, documentation with these professional, I mean, because you're actually finding ways to pay the provider for the service that they did. And I'm thinking, to your point, like a surgery, your surgery, cut and dry, this is what you did. If you did something that is off from what the actual CPT code definition is, then you would accentuate that with either add-on codes, modifiers, etc. But at the end of the day, your documentation has to suggest, why did you add these codes on? Why did you add these modifiers? Why did you all of that? Which has always been the case. But your diagnosis is, why did you have to have the surgery in the first place? And I think that, i.e. medical necessity. So I think that's where that part plays. I don't know. Maybe I'm missing something. I don't know. And I'm thinking only on straight procedure stuff. E&M is a whole different animal. And so
right.
That's a whole different animal. And I've always been under the impression, even when we had the older system where you had the 3 key components, the medical decision-making part of the E&M service, to me, always helped justify some of the things that happen for the provider. Like, your exam can prove that you were there if you documented that you touched this, looked at that, whatever. But that medical decision-making was, for me, and when I provided provider education, I'm like, this is telling your story. This is telling why you feel you need to do XYZ. You're ordering this, you have assessed this, whatever. This is where the meat And they have, I guess, miraculously agreed with that, and that's why it's now the E&M codes are now based on that medical necessity, or I'm sorry, medical decision making piece. But I don't know. Like I said, that's just an interesting thought as I was listening to myself read those questions. All right. Well, go ahead.
Did I mention last week, because while we were talking, did I mention last week about all the spike in doctors going to Canada?
You did. You did. Did you find out more information about that?
Because I was just wondering, like, how all this, because honestly,
Does this all tie in together?
But I think it's just overall, I think it's a good opportunity for nurse practitioners. But I just want nurse practitioners to really go and get some E&M training.
They need some training on documentation, period.
Exactly, because
across the board.
Because they have to. I don't know. There's just a huge gap, and I think that if they really got it together, they could really come in and fill the gap and kind of like really make more of an impact, because they make an impact now, but more of an impact.
Right. And I saw somebody, I think this was on LinkedIn. Somebody was saying something about the payment for RNs, and you don't have that in outpatient professional. So I didn't understand that correlation either, even though that it was related to this RFI, but somebody was bringing that up. And I was like, no, when you're paid for your inpatient care, all of that is included and bundled into what the payment is for. They don't have nothing to do with over here. They don't do that. So I think a lot of people were just reacting versus responding. They heard something, they saw it, versus let me sit with this for a minute and really try to appreciate and understand where we're going. And I think that's a little bit of what we're doing today.
Right.
All right. So here's the real question for every coder, CDI specialist, and compliance officer listening. Why should you care about a request for information that isn't even a proposed change yet? Because if CMS eventually acts on any of this, if physician payment moves toward ICD-10 PCS or toward bundled DRG style payment categories instead of individual CPT codes, or if the CPT and RUC process gets restructured entirely, that reshapes coding education, certification content, compliance auditing, and revenue cycle operations from the ground up. This is the kind of RFI that years from now, we may look back on this moment and this conversation on how this all started. Like, we're now doing this. Why are we doing? Remember, it was always about the why, knowing the why. Why are we now doing this stuff this way? Because of these types of conversations right now, because this RFI that came out, it's going to be interesting. It really is going to be interesting. And here's the good news. This is a genuine open comment period. Again, you as a working professional in this field have standing to submit a comment. CMS actually really wants to hear from the people actually doing this work every day, not just from the AMA, because they gonna put their hat in the ring. They're probably getting their members lined up right now. Everybody better send a comment. And the specialty societies, September 14th, not too far away in the distant future, is the deadline. So, consider and think about those questions and submitting a comment. All right. Mr. Jesse, do you have any closing thoughts?
I'm just going to sit back and wait for the fallout, because no,
that's going to be the best conversation, right?
It's going to be a whole lot of whiskey drinking over these next couple of months and years and I was, and it would be comical. I know they wouldn't do it because it would be too much of an upheaval. But if they would have changed CPT at the same time that they switch over to ICD-11, that would be hysterical. Hysterical.
And they got some HIPAA changes in the works, and oh my goodness. Somebody often talks about the quote unquote other elephant in the room, which is actually the EMR or EHR domination with Epic and that whole piece. So it's a whole bunch of players in the game. So it's gonna be real interesting to see how this all falls out.
Honestly, I don't know. I think it's gonna be hard to not that it can't be done, but it's gonna be hard to beat Epic, because when I tell you it's amazing. It is because we don't use it where I work now, and it's a struggle. Especially having seen how it works and how easy it is. Like, even just like, because every time I have to look for labs, it just grinds my gears. Because in Epic, you can just you can filter it by encounter, year, day.
Well, I think some of that is the IT people behind the thing. So, maybe these other systems may need to figure out and find ways to do, because clearly it can be done. So other systems need to figure out what it is they need to add to their systems to make sure that it can get done. And unless that's some type of proprietary information, because Epic is on one. They won't even let the educators use their stuff. So it's like, really? They are on one.
And honestly, I can't really blame them.
Yeah.
I mean, because it is good, and their only competition is Solventum. Bless their hearts, they're not going to be able to do it.
Well,
they should have just.
Who are they? I mean,
they were 3M. Now
that's what I said. Next year they're going to be somebody else, and this one.
I mean, because I just think that when it came to an encoder, once again they were the best encoder I've ever used. Like, but they try to do too much. Like, find a lane and stay in it.
Mm-hmm. She is, but isn't the owner of Epic a healthcare provider?
I don't know her story, because I've seen it. She has a story of how she created it. I think she was in healthcare. I don't. So it's interesting.
Mm-hmm. But we can pull all that up in the meeting after the meeting. How about that?
She's sitting pretty now, I can tell you that.
Amen. She ain't providing nothing right now except
okay.
All the
and it would make sense that a doctor would come up with it. It would.
Mm-hmm. It would.
Find a need and
others would have the same type of provider interaction or input into their product as well, knowing that these are the people that are using them. Interesting. All right then, y'all. That is our tea for today. Remember, it could all be so simple when someone hands you the plain language version of a 60-year-old coding system. Suddenly, back on the table with some questions, some concerns, and some food for thought. I'm Clarice Warner, the girl with the pearls. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend. And to my Patreon Tea Sipper family, we are back. We will see you at the meeting after the meeting. Mr. Jesse, you want to have anything else? Or are we good? For the good?
We're good.
We're good. All right. We'll see you guys later. Thank you for joining. Have a great weekend. Bye.